water. So what's its function? Its function is its neutralizes. So when you have acid production in the stomach, from you smelling food, seeing food, tasting food, you get a production of bicarbonate and water. It migrates itself back up towards the stomach, and it neutralizes acids. We know people produce sometimes way more acids than what we can neutralize, and so they'll take medications to try to help counteract that. You take a Tums for indigestion. People are on proton pump inhibitors, those kind of things that they take to help with the situation when we don't produce enough of these. And then what is secreted by the acinar cells? Those are enzymes for digestion. And I'm sure you went over this in A&P, but here they are. Lipase, of course, is available to break down fat. Trypsin is available to break down protein products, and amylase breaks down carbohydrates. So those are our three types of pancreatic enzymes. On the next page, it says, describe the relationship between the cephalic, the gastric, and the intestinal phases of digestion. How does it stimulate pancreatic secretion? Well, you can see that in the cephalic phase, there's stimulus of the vagus nerve. That vagus nerve actually causes stimulation of the pancreatic secretions. And when we have those, we have differences in our pH. And when we have a low pH, we secrete secretin. And we have fats and peptides stimulate the release of CCK. And secretin stimulates the duct cells to secrete that bicarbonate, and the CCK stimulates the acinar cells to secrete digestive enzymes. So between the two, the digestive enzymes should go south down into the bowel, and it helps break down any type of food particles that we eat, and that's how we get our nutritional value from it. And then those secretin stimulates that bicarbonate and water, and it should go back up towards the stomach, and it helps neutralize the acids that are there. So it's kind of a complex system of producing enzymes, factors that stimulate those, and then the shutdown process. So when we have issues with our pancreas or stomach or our bowels, we try to shut down that process by making our patient NPO. And when we make them NPO and we don't let them eat or drink, then hopefully the production of pancreatic enzymes should also be minimal or only very little that it should secrete. So this is just a little more of a detailed picture, and then you have a real simplified one on your notes. Number 4 on there, it says, note that pancreatic secretion is controlled by enzymes. We talked about that. And then I think the most interesting thing in that is that the amount of pancreatic enzymes that are normally secreted is somewhere between 1,500 to 2,500 mLs per day. So if you look at a 2-liter bottle, that's around 2,000, okay? So think of that 2-liter bottle being filled for the amount of enzymes that you secrete. So it's a lot. So you can see when we look back here, oops, I thought I had a picture of that. If you look at the picture on the front of your page again, and you look at where that common bile duct comes out, it is the same place that our digestive enzymes come out. So somehow that is blocked. Those digestive enzymes are building up within the pancreas, and that's pretty much why our patients are coming into the emergency room, because they're having such severe pain from that enzyme buildup in there. All right, that leads us to our first problem. Oh, here. I knew I had a picture of this. So if you look at, here's the pancreas. Go back. See if I can. So here's the pancreas itself, okay? And you can see in here, our acinar cells are producing our digestive pieces, and so they're coming down here, and they're coming through the outlet. Well, you have your gallbladder here and your liver. So where does your bile come out? It comes out here and gets excreted at the same time. So the gallbladder is always dumping its bile. And and it's coming out the same hole. Well, unfortunately, what if we would have a big gallstone right here? Okay. Now what happens to our digestive enzymes that are trying to come out and be excreted from the pancreas? They get backed up in here, and so it causes us all kinds of problems with the pancreas. So this picture is just to portray the fact that if we have any type of liver or gallbladder issues, it may not be a pancreatic issue. It could be something causing some type of swelling here at this outlet that will not allow the digestive enzymes to take place. Okay, so that's kind of why I show the picture of this, just so you can get some idea of what's happening within the pancreas. All right. Oop, I gotta clear that. I realize that stayed for the whole thing. Clear. There we go. Okay. So the first real problem that we're talking about, because I don't really talk about pancreatic CA, is just going to be pancreatitis in general. And we're going to talk about two different types. So acute pancreatitis and chronic pancreatitis. So the first one is acute. Incidence is about 5,000 cases in the United States, 1 in 5. Pretty common. 75% of those are mild to moderate. We had a young lady, or a young man, I can't remember, yesterday at Ashland, was about 25, that had pancreatitis. I think it was a young mother, because she had recently had a baby. So the incidence for mild to moderate is pretty significant. Severe, however, does not happen that often, but when it does, it can be fairly detrimental to the patient. They can be in ICU and have multiple issues. They tend to be biliary tract related, so oftentimes moms can have gallstone issues when they're pregnant. People in their 50s and 60s can have issues. And then we're probably more familiar at times when it is alcohol related, and that tends to be more in our young males. So biliary usually for our little older folks, and then oftentimes alcohol related for our younger males that come into the hospital. And then etiology, why does it happen? Well, if you look at the alcohol piece, the exact mechanism for why alcohol causes problems is not 100% clear, but it does stimulate a lot of acid production. It puts a little increase on the amount of pancreatic enzymes that are going to be released. And then in that outlet area, it can cause spasms or swelling of that area, so that can impede how well those digestive enzymes are being released. The second type is gallstones. And we see cholecystitis with gallstones can be an issue for pancreatitis. And I showed you where that blockage could occur if we had a stone. So that backs up, and then trypsin itself can activate, and it can actually start munching on the pancreas itself, and that's where they get their pain from. The third type is postoperative complications. If we had any type of surgery to that area, we had a gallbladder removal, we had a small bowel resection, we had bypass surgery, we had gastric banding for obesity. Any of those things could cause a post-op complication where you have swelling at that outlet. And again, if it swells, we could have problems with enzymes not being completely released, so they back up and cause them issues. The fourth and final one would be some type of bacterial infection. Your book does talk about that, in some type of abdominal trauma. So if you were in an accident or had some type of blunt trauma to the abdominal area where it caused swelling or bruising, you could have pancreatitis exacerbated from that. There are some procedures that we can have done. One of those is an ERCP. It's done like an EGD. So we put the scope down the stomach, it comes out into the small intestine, and then actually can go back up for gallbladder stone removal. But the procedure itself, unfortunately, can cause pancreatitis. So when the patient signs their consent for their ERCP, for their gallbladder stone removal. One of the complications that the surgeon or the specialist will talk about is, when I do this procedure, one of the complications from having this done is pancreatitis. So the patient's taught to watch for severe pain, those kind of things, a couple of days post-procedure to make sure that the edema or the trauma to the area of that scope going up in there doesn't cause them to have pancreatitis. So some of our everyday procedures can actually cause pancreatitis for us. All right, pathophysiology then. I have it written out for you, and then I just made a slide telling you the same thing. Trypsin does digest the pancreas.
No.
It doesn't know enough not to start chewing on the pancreas because normally those enzymes would be out into the small bowel and they would be digesting food particles. Well, it doesn't know enough to do that, and we don't produce enough trypsin inhibitors for that not to take place because we talked about the volume of enzymes being released, which are large, so there's not enough trypsin inhibitors for that not to take place. So it can cause edema. In severe cases, it can cause necrosis, and they can actually have hemorrhagic pancreatitis from it. Elastase is activated, and it allows for blood loss. Lipase is activated, and it can cause fat necrosis. Kinins are activated. That's just to be an arrow, not a number 6. When it updates, sometimes the arrows become numbers instead of but they cause vasodilation and increased permeability, and it increases the risk then of hypovolemic shock because instead of the fluid staying within the vascular system, it actually causes vasodilation and it allows that fluid to seep out. So the loss of fluid can cause a hypovolemic shock. And I have a diagram that will kind of show this a little better in another page. So that's the first part of it. So trypsin is activated, lipase is activated, causes fat necrosis. We have kinins that are kind of stimulated and they cause vasodilation. They cause fluid loss, even blood loss, and it can cause shock for us.
So the fluid leaks out of the vessels, is that what you're saying? Okay.
That's correct, actually. Yep. So normally they would stay, but because of this kinin release, those fluids do not stay. It increases that permeability and the fluid leaks out. Now, it's not gushing out. It isn't like we slice the vessel or anything like that, but over time, they will have a third spacing of fluid, okay, from that. And remember, the more we talk about severe problems, this is not your mild case of pancreatitis. This is more of your moderate to severe patient. So I'm giving you the worst case scenario. The more common symptoms would be a pain, nausea, that kind of thing that would bring them into the hospital. But progressively, the patient can become worse. Okay? So I give you the worst case things that can happen, but generally 75% of them are mild and they have pain, just need to be NPO for a while, give that gut a rest, let us resolve their gallstones, let us resolve the other issues that are causing it, and then the pancreatitis should resolve on its own. So the second part is this. In the severe cases or the moderate, is those pancreatic enzymes can seep into the abdominal cavity. They can also go into the thoracic cavity via the lymphatic channels, and they can have fluid shifts. So we could have fluid buildup within our lungs. We can have fluid buildup within our abdominal cavity also. Number 3 says that this autodigestion is normally prevented. We have inhibitors that are released. Unfortunately, we talked about, due to the large volume of enzymes that are being produced, the inhibitors can't keep up with it. It was only meant to take care of a few stragglers that didn't make it out of the pancreatic ductwork into the small bowel, and then those inhibitors take care of those few stragglers. This is the whole system. Shooting batch is not getting out at all, and it was never meant to take care of that large volume. So that's why we get a lot of symptoms when they have pancreatitis. Signs and symptoms then. Pain is our biggest complaint. The biggest thing that probably will bring the patient to the emergency room is pain is unrelieved. So it can be mild to severe. It's usually fairly constant. Usually the onset is within 24 to 48 hours after meal or alcohol ingestion. The complaint can be left upper quadrant to mid-epigastric pain, and they are more comfortable when they have their knees drawn up or they're in a sitting position. So being completely in a supine position, totally stretched out, would not be comfortable for them. If you've ever had abdominal pains, menstrual cramps that are very bad, you know that you're more comfortable if you're in more of a fetal position than you are if you're completely stretched out. So that's just kind of a common sense thing that you will see with your patients. 2, for their GI system, nausea, vomiting, guarding, jaundice. So oftentimes your pancreatic patient comes to the floor with orders that say if continued nausea or emesis, they need to have a nasogastric tube placed. We don't routinely do it on all of our patients anymore because just resting and not giving them any oral content usually is sufficient. But if they have a lot of nausea, a lot of vomiting, we will go ahead and place a nasogastric tube. Sometimes it gets put in the ED. Sometimes we just wait to see how the patient will be once they reach the floor. But if it continues, they do get a nasogastric tube. Guarding, so they're more comfortable holding hands and stuff across their abdomen. They don't like you pushing on it. Abnormal stools, so when they do go to the bathroom, they tend to be bulky, very foul smelling. Excuse me. Normal fat content in stool is only about 20%. So these